Good morning, Dr. Smith. So, for today's case explainer on our teaching rounds, I've got a patient who perfectly illustrates some absolutely vital diagnostic nuances and management strategies for Crohn's disease. As a resident, I see firsthand how misinterpreting early signs can severely delay critical care. So today, we're going to walk through a recent admission, evaluate the clinical reasoning, and then really break down the pathophysiology layer by layer so we can definitively separate this disease from ulcerative colitis. We'll also examine the exact procedural workup, outline our ward management plan, and review those clinical pitfalls that routinely cost our patients precious time. Let's just dive right into the admission. Our patient is a 23-year-old guy who came into the ED with a 6-month history of abdominal pain and loose stools. He's reporting about 4 to 6 loose, mucus-containing stools a day. Now, he hasn't noticed any gross blood, though he admits he hasn't exactly been looking closely. But here's the kicker. He has lost 8 kilograms over the last 6 months without even trying, and he's dealing with some profound fatigue and malaise. But the absolute key to localizing his disease is the specific nature of his right lower quadrant pain. It's crampy, and it reliably worsens exactly 30 minutes after meals. What we're seeing here is the gastroileal reflex in action. Feeding stimulates this reflex, which aggressively pushes chyme into a narrowed, highly inflamed terminal ileum. So that pain, it is literally the bowel attempting to force a meal through a swollen, strictured segment. This postprandial pain, combined with that involuntary weight loss, points our clinical compass directly at the small bowel, not the colon. Which of course begs the question, what on earth did his prior workup miss?
Well, let's get into Act 1, the admission presentation, which is really a clinical history of misdirection. Looking at his pertinent history, he's 23 years old, putting him squarely in that 15 to 30-year age bracket, which we know is the first and largest peak of onset for Crohn's. No family history of IBD. He is a smoker, though, about half a pack a day for the last 5 years. He also mentions having recurrent, painful mouth ulcers. Now, interestingly enough, his previous providers told him he simply had irritable bowel syndrome. I really want to highlight how frequently young patients are misdiagnosed with IBS, but IBS should literally never be a primary diagnosis when a patient has involuntary weight loss and nocturnal symptoms. Actually, when we dug a little deeper into his surgical history, he casually mentioned having a, quote, hemorrhoid drained about a year ago. On physical exam, he looks chronically ill. He's thin, temp is 37.6. On his abdominal exam, there's a palpable fullness and tenderness in the right lower quadrant, but thankfully no rebound or peritoneal signs. He also has 2 aphthous ulcers right there on his buccal mucosa. Crucially, we did not skip the perineal exam, and upon inspecting the perineum, I found perineal skin tags and a healed fistula opening. Doing the perineal exam here essentially is the diagnosis. It proves that the hemorrhoid he had drained a year ago was actually a perineal abscess, and that single physical finding completely shatters the old IBS label.
Moving on to his initial lab studies, they tell a really precise anatomical story. His hemoglobin is 10.8 with a low MCV, so microcytic anemia. His CRP is markedly elevated at 68, which confirms active systemic inflammation. Stool infectious studies were all negative, but his fecal occult blood test, positive. Remember, he denied seeing blood, but about 50% of these patients will have a positive FOBT. Visible blood is uncommon, but occult blood is extremely common. Basically, a negative history for hematoschiaza proves nothing. You simply have to test. Finally, his albumin is low at 2.9, and both his vitamin D and B12 are markedly low. I really want to defend this specific read for a second. Seeing a low B12 combined with a low albumin tells us definitively that the terminal ileum is fundamentally failing. It's physically too inflamed to absorb complex nutrients, throwing him into a systemic state of malnutrition.
Let's transition to Act 2, the pathophysiology deep dive, where we'll build the mechanism layer by layer to explain the biological why behind all these clinical signs. The development of Crohn's disease follows a very specific pathophysiologic cascade. Step 1 is a genetic predisposition, frequently involving NOD2 mutations, which we see more often in Caucasian and Jewish populations. Step 2 requires an environmental trigger, specifically a defective mucosal barrier, and this is heavily exacerbated by smoking. Smoking fundamentally alters the gut microbiome and compromises mucosal blood flow. It triggers localized ischemia that just worsens the barrier defect. This, by the way, is a stark contrast to smoking's paradoxical and, frankly, poorly understood protective effect in ulcerative colitis. Step 3 is T-cell dysregulation. We see a fundamental loss of immune tolerance to normal luminal antigens, driving a massive Th1 and Th17 cytokine response. Now, up to this point, the cascade is broadly similar to UC. But step 4, this is where the two diseases completely diverge.
Step 4 is transmural inflammation.
Transmural. It is literally the single most important word when we're talking about Crohn's disease. Everything distinctive about Crohn's follows from this one concept. Unlike ulcerative colitis, which stays superficial and isolated to the mucosa, Crohn's disease involves inflammation that affects the full thickness of the bowel wall. Let's look at the wall layer by layer. The inflammation penetrates the mucosa, it invades the submucosa, destroys the muscularis propria, and eventually breaches the serosa. Because the inflammation spans all 4 layers, it drives every single structural complication we see. Full-thickness inflammation can do 3 devastating things that mucosa-only disease just can't. First, it can tunnel out. When inflammation breaches the serosa, it seeks adjacent structures, creating fistulas. Depending on what it connects to, it could be an enteroenteric fistula into another bowel loop, a rectovaginal fistula, an enterovesicular fistula into the bladder, an enterocutaneous fistula out to the skin, or a perianal fistula. Second, transmural inflammation can scar circumferentially. It replaces smooth muscle with dense collagen, creating a fibrotic stricture that standard immunosuppression simply cannot reverse. And third, it can microperforate and seed infection outside the bowel wall, creating an intra-abdominal or perirectal abscess. Mucosa-only disease does absolutely none of these 3 things.
So, if we systematically contrast Crohn's disease with ulcerative colitis based on these structural features, we can easily separate them point by point. We already established depth, right? Crohn's is transmural, UC is mucosa only. Next is distribution. Crohn presents with skip lesions, meaning areas of severe disease separated by completely normal mucosa. UC is strictly contiguous. It always begins at the rectum and marches proximally without any interruption. In terms of location, Crohn has a mouth-to-anus reach. Think back to our patient's buccal aphthous ulcers, while UC is strictly limited to the colon. And finally, when you're looking at the tissue during an endoscopy, Crohn features a non-friable mucosa. UC, on the other hand, is marked by a highly friable mucosa that bleeds super easily on contact and loses its normal submucosal vascular pattern.
Because Crohn's disease can strike literally anywhere from mouth to anus, we really have to understand where the disease typically lives. Isolated upper GI tract disease is pretty rare. About 25% of patients have isolated small bowel disease or ileitis. The largest group by far, representing 50% of patients, have ileocolonic disease. Another 25% have colonic disease only, and I really want to highlight this specific colonic-only cohort. They can be incredibly difficult to distinguish from UC endoscopically unless you take deep biopsies to evaluate for that transmural depth. This overall distribution perfectly explains why a standard colonoscopy alone is fundamentally inadequate for a diagnostic workup. Think about it. With 25% having isolated small bowel disease and another 50% involving the terminal ileum, one lower endoscopic test alone can never map the full extent of the disease. The small bowel absolutely must be imaged. Furthermore, 24% of patients have perianal disease. This includes fissures, fistulas, skin tags, and perirectal abscesses. Crucially, this perianal disease can actually precede intestinal symptoms by years. It acts as a sentinel warning sign that is, unfortunately, far too often missed by primary care. A young adult presenting with a recurrent perianal abscess deserves a full inflammatory bowel disease workup. As we established earlier, this is exactly what happened to our patient a year ago when his sentinel abscess was misdiagnosed as just a routine hemorrhoid. Now, when the terminal ileum is involved, which it is in roughly 75% of patients, we must proactively anticipate the downstream consequences of its failure. The terminal ileum is where highly specialized absorption happens. When it fails, we see a predictable, really devastating malabsorption chain. It's like a domino effect. First, decreased bile acid absorption alters the cholesterol saturation index in the gallbladder, which leads directly to gallstones. Second, decreased fatty acid absorption means that unabsorbed fat remains in the intestinal lumen, heavily saponifying with calcium. This leaves oxalate, which normally binds that calcium, free to be hyperabsorbed into the bloodstream, ultimately precipitating as calcium oxalate kidney stones. Third, decreased absorption of fat-soluble vitamins leads to vitamin D deficiency, causing osteopenia and early-onset osteoporosis. And finally, because the terminal ileum is the exclusive site for its receptor-mediated uptake, ileal failure entirely prevents vitamin B12 absorption. So one single anatomic site failing creates these 4 distinct systemic complications. All right, let's move into Act 3, Assessment, Plan, and Ward Management. It's time to commit to our diagnostic strategy. For his procedural workup, our plan requires 2 distinct studies, an ileocolonoscopy with biopsy plus an MR enterography. Like I mentioned, because of the heavy disease distribution in the small bowel, we just can't rely on a colonoscopy alone. We have to map the full extent of the small bowel involvement.
We use MR enterography over CT enterography specifically to spare this young patient from massive cumulative radiation doses over his lifetime, while also getting superior soft tissue contrast to identify transmural edema and any subtle fistulas. And for the GI attending performing the scope, intubating the terminal ileum is the one procedural step that absolutely must not be skipped. So here are our patient's specific endoscopic and histologic results. The endoscopist found an ulcerated, cobblestoned terminal ileum. Classic severe ileitis. Just to be clear on the physical mechanism here, cobblestoning happens when deep, crossing linear and transverse ulcers carve into the wall, leaving these islands of normal edematous tissue bulging upward in between them. He also had patchy right colon disease, but his rectum was entirely spared. We saw normal-looking mucosa in the skip areas between lesions. Rectal sparing, plus skip lesions, plus normal mucosa in between, that is the definitive endoscopic signature of Crohn's disease. Histology confirmed transmural inflammation with a dense mononuclear cell infiltrate. But notice this, there were 0 granulomas found on the biopsy. I really want to stress this point to the team. Non-caseating granulomas appear in fewer than 25% of mucosal biopsies, so their absence never rules out Crohn's disease. Finally, his MR enterography revealed a 12-centimeter inflamed ileal segment, but thankfully no hidden abscess and no internal fistulas were seen right now. To track his progress on the ward, we need to objectively score his disease activity. The 2 primary scoring indices are the Crohn's Disease Activity Index, or CDAI, and the Harvey-Bradshaw Index. The CDAI is the clinical trial standard. It heavily combines symptoms, physical findings, hemocrit, and weight into a single complex score. But for our day-to-day ward management, I strongly recommend the Harvey-Bradshaw Index. It's the clinical shortcut. We can run through it rapidly at the bedside by just ticking off 5 parameters: general well-being, abdominal pain, number of liquid stools, presence of an abdominal mass, and current complications. Honestly, whichever you choose, the real value lies in using one consistently to track the trajectory of the disease over time. Next up, we need to stage his disease precisely using the Montreal classification, which defines his clinical category based on 3 axes. For age at diagnosis, he scores an A2, which is adult onset between 17 and 40 years. We know younger onset reliably tends to run a more aggressive clinical course. For location, he is L3, meaning ileocolonic involvement. And for behavior, he is currently B1P. The B1 means his disease is strictly inflammatory at this moment, without stricturing or internal penetrating behavior. But that P modifier, that heavily denotes his active perianal disease. It's incredibly critical to understand that Crohn's disease is highly progressive. While he is B1 today, over the next decade, his disease behavior is highly likely to migrate to B2, meaning stricturing, or B3, meaning penetrating, as that transmural damage inevitably accumulates. Let's dive right into our immediate ward management plan. First, due to his ileal failure, we must proactively replace his vitamin B12 and vitamin D, and we're going to order a DEXA bone density scan to evaluate for early osteopenia. Second, and I absolutely cannot stress this enough, we must counsel him on smoking cessation, not just as generic health advice, but as a critical disease-modifying medical intervention. Smoking specifically increases the risk of Crohn's disease, and it's strongly associated with more aggressive disease and a much higher lifetime need for surgery. It is the single environmental risk factor he can actually change today. Third, we need to counsel him on his elevated thromboembolic risk. Systemic inflammation drives a dangerous hypercoagulable state via elevated acute phase reactants and endothelial dysfunction, especially during active flares. Finally, while drug selection by severity is a separate pharmacological discussion, we will immediately perform a comprehensive infection screening, including TB and Hep B, so he is fully cleared before we initiate any biologic therapies. And that brings us to Act 4, Dispo and Teaching Pearls. Let's project the patient's long-term trajectory and cover some crucial clinical pitfalls. When discussing prognosis, we owe our patients the honest numbers, because honesty builds far more trust than false reassurance. At 1 year, roughly 50% of patients are in remission, 20% are actively flaring, 20% maintain low disease activity, and 10% remain chronically active. So half are well at any given point, but the disease rarely disappears entirely. Looking out to 20 years, the reality is that the vast majority of patients will require some form of bowel resection, and we must make it absolutely clear that unlike a colectomy, which cures the colitis in UC, surgery in Crohn's disease is never curative. The disease reliably and aggressively recurs right at the surgical anastomosis. Finally, we do need to acknowledge that life expectancy is slightly reduced. It's a real, albeit modest, reduction compared to UC, where life expectancy remains statistically unchanged. To close out our rounds today, I want to quickly summarize the core clinical mistakes we see in practice, pitfalls that, quite frankly, perfectly mirror the missteps in our young patients' prior care. Number 1. Calling 6 months of postprandial pain and weight loss irritable bowel syndrome. IBS simply does not cause involuntary weight loss. Number 2. Never examining the perineum in a young patient presenting with chronic diarrhea. Number 3. Excluding Crohn's disease simply because the mucosal biopsies showed no granuloma. Number 4. Escalating steroids in a non-improving patient without first imaging for a masked abscess. Number 5. Attributing obstructive symptoms like obstipation and colicky pain to a simple inflammatory flare when a fibrotic stricture is actually the mechanical cause. And number 6. Forgetting to meticulously monitor B12, vitamin D, and bone density after ileal disease or surgical resection.
So, I'll leave you with this. When our Crohn's patient is admitted and just isn't improving despite all our interventions, we have to pause and ask what is probably the most dangerous question on the ward. Are you treating a stubbornly active flare, or are your high-dose steroids just blunting the fever, blunting the white count, and effectively masking a transmural abscess? Remember, full-thickness inflammation seeds infection. You need a high index of clinical suspicion, not a falsely reassuring physical exam. Always image before you escalate immunosuppression. Thank you for your time on Rounds today, Dr. Smith.